All right, we're live.
All right, we are back from break. Senate Health and Welfare, April 8th. I think it's still April 8th. Yes. So Ina Backus is here, Director of Healthcare Reform. And Ina, thank you for coming in to talk with us today about some of the healthcare reform initiatives going on. And I think you were going to present the all-payer model next gen. And do we have something from you on our documents? Yes. So we're looking at the health improvement plan. So I am just going to let you present, and don't be concerned about going over a little bit. We have started late, and the next topic is one that we're returning to and will become more of a conversation with the committee and others. So what you have to say is really very important to us so we can understand the current improvements that are going on around healthcare.
Thank you. For the record, my name is Ina Backus. I'm the Director of Healthcare Reform at the Agency of Human Services. When it's time to do so, would it make sense for me to share my screen?
Yes.
Okay. Before I get into the screen sharing, because we last had a discussion about the healthcare reform initiative, the all-payer model, it seems like weeks ago. It might not have been fully weeks ago, but some time ago, I wanted to review the major objectives for the all-payer model agreement and recap the basic performance issues that we've seen to date in the agreement, so that you have a sense of the implementation improvement plan initiatives that I'm going to describe, and why we've identified certain activities in terms of implementation improvement. The fee-for-service reimbursement model emphasizes acute care over preventive care, which is really a key concept in our move away from fee-for-service through the all-payer model agreement. By emphasizing acute care over preventive care and being a system that is rooted in billable transactions, rather than paying providers for some of their most important work, which includes primary care providers that spend their time coordinating care for their patients, and primary care providers that are addressing social determinants of health for their patients. These sorts of activities aren't rewarded by the fee-for-service system. In fact, fee-for-service system does not provide reimbursement for time spent doing these essential activities, particularly for primary care providers. That's a key concept. That's a key thrust in why we're working within a program of reform to move away from fee-for-service reimbursement. In a fee-for-service reimbursement system, there are no links between payment and the quality of care that's delivered for patients. There are no links between the health outcomes for the population that's being served through the fee-for-service system. Ultimately, the fee-for-service system is not linking the payment to the outcome of health that we want to see in a high-performing healthcare system. The state of Vermont, as I talked with you about in our last meeting, has an agreement to move away as an entire state on a statewide basis to move away from the fee-for-service reimbursement system towards a system that rewards health outcomes, towards a system that provides predictable and sustainable revenue for healthcare providers. The agreement asks, and the state agrees, that the movement away from fee-for-service take place across the three major payer types of healthcare. That's why it's referred to as the all-payer model, because it includes the major payer type that is Medicaid, the state Medicaid program, the major payer type that is our federal program for older Vermonters and Americans, Medicare, as well as it includes goals and priorities to move away from fee-for-service reimbursement for commercial payers in the healthcare system. We have finished 3 complete performance years for this agreement, and we are in performance year 4 now. Performance year 4 in the agreement began on January 1. Looking back at the 3 complete performance years, we can see areas for improvement in this agreement. Like I said, the agreement is a statewide agreement, and it does assume that value-based payments are made at the conclusion of the agreement on behalf of most Vermonters in the state. It's really pushing the state to move away from fee-for-service on as large a scale as possible. And so the agreement has scale targets. One place where we need to do more work to improve our performance is in the area of scale. Scale really drives the ability of the system to moderate healthcare costs growth through the alternative payment model. Scale also drives the system to improve quality and health outcomes. The more payers that are participating, the more providers participating, the more Vermonters whose care will be influenced by this alternative to fee-for-service arrangement, the value-based payment model. I'll share my screen now to talk about the implementation improvement plan. And hopefully you're able to see my screen at this time.
Yes, looks good.
Do you prefer to see it in the slideshow mode? I can do that as well.
Yeah, actually, it makes it easier to read, especially when you have a table like this. There. Oh, that's great.
Great.
Thank you.
The implementation improvement plan for the all-payer model agreement includes activities that focus in a few key areas. The activities included in this plan focus on Vermont's relationship with our federal partners, because Medicare is a key participant in this agreement, as well as the agreement itself.
Excuse me, I'm sorry to interrupt you, Ina, but the thing that is on our website for under your name for today is not what you're showing on the screen. It's from March 25th. That's a different presentation, isn't it? Because I can't.
It's not. This is actually the same one. If you move to slide 16 in the March 25th presentation, that's
Okay.
where this begins.
I hadn't gone down far enough. All right, thank you.
The activities have some key areas of focus. They focus on our actual state and federal partnership and the agreement we have with the federal government and how that we can improve upon that. The implementation improvement recommendations also focus on the Green Mountain Care Board, some recommendations about how the alternative payment model and the regulatory system evolves to look at the value-based payment design, also focusing on AHS and how we organize healthcare reform and healthcare activities at the agency in service of achieving the objectives of the all-payer model agreement, which include scale of participation, certainly, as well as improving health outcomes. Importantly, improving access to primary care, reducing deaths due to suicide and drug overdose, and reducing the prevalence and morbidity of chronic disease in the state of Vermont. And finally, the improvement plan also includes recommendations that are directed at OneCare Vermont. The value-based payment model that is prescribed in our agreement is one where an accountable care organization is the entity that can accept the value-based payment. It's a network of providers that work together. OneCare, as we talked about last time, is the only accountable care organization that is operating in the state of Vermont, and it is participating to meet the objectives of this agreement, which is why we have recommendations in the implementation improvement plan that are directed at OneCare Vermont as the participating ACO. I'll talk through these recommendations, and I'll also provide some status updates with respect to our progress with the recommendations. As we discussed, we have not met the scale targets in the agreement for the all-payer model. Scale is a very important objective, as I just talked about with you. It's important that we have a scale of participation to be able to realize the cost containment objectives, and of course, so that as many Vermonters as possible are impacted by the value-based payment program. One thing about value-based payment programs is there is an expected and usual spillover effect. So while not all payments might be captured in a value-based payment design, when there are active value-based payments in a healthcare system, there can be a spillover effect in that healthcare providers are providing services similarly for their or in a uniform way for their patients, regardless of what payment model they're necessarily attributed to. And that's something important to note. But again, scale is very important for this agreement. However, the agreement does have some technical aspects to it that that create a scale target that doesn't reflect our actual capacity to meet the scale target. And I'll give you an example of that now. The agreement largely operates through primary care providers that participate with the ACO. And when a person has a relationship with a primary care provider participating in an ACO and their payer is participating, for example, Medicare does participate in this program, that person is then attributed to the all-payer model, and they are counted in the scale target calculation. If a Vermonter has or receives the majority, has a provider that is in, let's say, Florida, and receives the majority of care out of state, that Vermonter can't be attributed to the model. Their provider doesn't participate as a part of the network of participating providers, and therefore they are not attributable to the model. Yet the state of Vermont in this agreement is responsible for those persons' participation. So that's being essentially counted against us as a part of the denominator of people who are eligible, and it's something that we'd like to address. We also suggested and proposed successfully to our federal partners that the risk corridor thresholds for the Medicare model be decreased in order to account for the financial burden of participation for hospitals. Hospitals that participate at risk in the Medicare model have to have money in reserve to cover that risk. When the risk is greater, the reserve requirement is as well. Recognizing the financial impact, certainly of COVID-19, we worked with Medicare to reduce these risk corridor thresholds so that the burden of participation for hospitals was not as significant for this performance year, the 2021 performance year. So we sought to do that with our Medicare, our partners at the Innovation Center for the Medicare program, and we accomplished that. That has happened. And as a result of that, there are more hospitals participating in the Medicare program in this performance year than there were previously. So we've seen not only that our federal partners were responsive and worked with us in this arena, we also saw the impact of this change to the model for the performance year that we entered in January of 2021. We are also working with CMS to create written guidance for the best practices for critical access hospitals that are participating in this model. Critical access hospitals are key participants in this model, but they have cost reporting requirements that are based on the fee-for-service reimbursement structure, and they need some additional guidance about how to satisfy those requirements appropriately when they are participating in value-based payment. And we're working with the federal government, like I said, on that. We also are working with our federal partners, and this is a key recommendation here. And when we think about where we want to go with value-based payment, there is a continuum of value-based payment. So there's a continuum of movement away from fee-for-service. The federal government defines value-based payment models as ones that have a link to quality and value. So there can still be a fee-for-service component of a value-based payment, but there's also a link to quality or value. In Vermont, we want to move as quickly as we can away from fee-for-service to an actual fixed prospective payment, meaning a budget that's provided to healthcare systems providers prospectively, and that they can live within for a period of time. The Medicare payment model that we're working in now is a value-based payment model. I don't want it to be confused that it's not a value-based payment model, but it is still reconciling to fee-for-service billing activity. And so it doesn't fully move away from fee-for-service. It doesn't provide that fixed and predictable payment to healthcare providers. Ultimately, healthcare providers are being paid through this Medicare program. They are being paid prospectively, but that payment is reconciled to the fee-for-service billing activity. This is a really important part of our approach to improve potential performance in this agreement, to improve on Vermont's movement away from fee-for-service. We need Medicare to participate and to mirror the program that we've created for Medicaid that includes a true fixed prospective payment. So we will be working on this with our federal partners to establish a path for the Medicare payment model to mirror the Vermont Medicaid Next Generation prospective payment model. I think I shared with you last time that we've seen the scale of participation from healthcare providers. It's clearly the healthcare providers are participating most actively in our Medicaid program because of the payment model, because of the predictability that it provides. I can go back and show you that slide if you'd like, so that you can have a sense of what the scale of participation looks like in Medicaid versus the other payer programs. Would that be helpful?
Yes.
So here you can see what scale looks like by payer type. And you can clearly see that the Medicaid, which is the lightest shade of blue, that our Medicaid payment model is garnering the most participation. Our improvement plan has a number of recommendations that really jump off of this information and evidence that the way the Medicaid model is designed is appealing to providers and is appealing for participation. So as I keep going through the recommendations, you'll hear me say more than once that we need to do more work to mirror the Medicaid model with Medicare. That's what I was just talking about, and also with commercial payers, so that we can improve participation.
Madam Chair, can I ask a question or should we wait till Ina's
Well,
finished?
so yes, go ahead, as long as it's a question of clarification. If it's something broader than that, it may be answered as Ina goes through her presentation, but I'll leave it to you.
Okay, it's sort of in the middle. I can put it out there and maybe if you're going to answer it later, Ina, then you can just tell me that. But we got testimony yesterday from quite a few primary care providers about these prospective payments and how they didn't take into consideration throughout the plan year if there were added patients in their practices or added providers in their practices, and that the payments were set at the beginning of the year and then were not changed for these additions throughout the year. I'm wondering if there's anything in the plans to address that issue, because we heard that it was quite a problem, especially for smaller primary care practices.
The plan doesn't include a recommendation that is specific to that issue. However, the plan does describe some recommendations for OneCare Vermont. And those recommendations encourage OneCare Vermont to focus on its core business. In this model, it's all of our core business to be certainly attentive to primary care and to be thinking about what is afforded to primary care through the alternative payment model. Between OneCare and primary care, I am sure that that is something that is of focus. Certainly evolving OneCare's primary care contracts, but I want to be clear that the contracts are between OneCare Vermont, the ACO, and the participating primary care providers. The state has an agreement with Medicare to pay OneCare Vermont differently, and then OneCare contracts with its provider network.
So do we not have the ability as the state to make changes in how OneCare is calculating those payments? It sounds to me like they're pretty inflexible in how they calculate the payments. And do we not, as the state, have an opportunity or an option of telling them they need to be more flexible in those payments?
The state does not govern the contracts between OneCare and providers. Those are contracts between private entities. So we do not govern those particular contracts.
So I think this is probably will have to move into discussion when we've got Ledge Counsel in the room with us, but it's a great question, Senator.
I'll go back now to the recommendations. Sorry for the scrolling. Another recommendation in the arena of our federal partnership is to ensure that the Medicare 2021 benchmark, and this is one that I should have said that we published the implementation and improvement plan at the end of November. And so we've been working on some of these, we've been working actively on these recommendations since that time, and some of them have been completed. So this recommendation is to ensure that the benchmark for Medicare in 2021 provides as much stability and predictability as possible, despite the ongoing uncertainty associated with the pandemic. This is an important recommendation because when the benchmark is established, it's established looking forward, but it's based on the history of healthcare activity prior. And as you can appreciate, the healthcare activity during the public health emergency and the pandemic has been highly atypical. And so it's important to ensure through the benchmark setting that there's a process to appreciate that atypical healthcare utilization. The next recommendation is for the state of Vermont to collaborate with CMMI, which is the Center for Medicare and Medicaid Innovation. and holds our agreement to encourage HRSA, the Health Resources and Services Administration, to prioritize value-based payment for federally qualified health centers. Federally qualified health centers have a different reimbursement model, and the federally qualified health centers, we want to see that the opportunity for federally health qualified centers to move away from fee-for-service reimbursement is also a shared priority with our federal partners.
Okay.
There are also a number of recommendations in how the Agency of Human Services specifically can organize and align its activities towards the goals of the all-payer model agreement. The first recommendation is for AHS and the Agency of Administration to conduct education and outreach to non-participating self-funded groups. This recommendation, again, is attending to the issue of scale of participation in this model, and to encourage more scale of participation by the self-funded groups. These self-funded groups are counted as commercial insurance in our scale target assessment. Since this recommendation was made, I think you're familiar that the state employee health plan members have been attributed to OneCare of Vermont for performance year 4, which we're in now in 2021. We also want and are prioritizing the integration of claims and clinical data in the health information exchange, and organizing and aligning the health information exchange within the Office of Healthcare Reform. So the Health Information Exchange program is now operating within the Office of Healthcare Reform in the Secretary's office at AHS, and we're coordinating the work of the Health Information Exchange along with the activities of its steering committee in service of the goals of the all-payer model agreement. And certainly we are advancing towards claims and clinical integration so that that is a resource that can be harnessed by providers who are in value-based payment programs, and so that providers can use the resource and not have to duplicate the resource using their own systems. So we're working very intently on this project. We are in the process of piloting the integration of Medicaid claims into the HIE, as well as pursuing the integration of commercial claims into the HIE. We're also recommending that we partner with OneCare Vermont and delivery system.
Ina, can I go back to that?
Yes.
So with the integration of commercial claims into the HIE, then the implication then is that all the quality analysis will include commercial claims, but those are only of, and you can correct me if I'm being inaccurate in this, but that would be for those lives that have already been attributed?
The goal for the integration of claims into the HIE is for there to be eventually the integration of all claims. So similar, we have our all-payer claims database. Right. You can imagine an end goal being a fusion of that database with the clinical information to be available as a resource for providers who are participating in value-based payment. And the reason being, those providers need to have insight into the clinical care that's being delivered and the quality of that care, alongside with the claims for that care, so that they can understand how to manage to the budget.
So so with the integration of commercial payers data into the system, then is that only for those patients who are attributed?
No,
Okay, so it's all, is it all patients who are all folks who are covered by commercial payers?
the goal is to integrate,
I
yes.
know, I understand the goal, but right now, what will this, where are we in this? in reaching the goal?
We are still working the details of this. So
Okay.
the
Well, there's huge implications, I would think, for a private payer who already has its own quality metric and data collection system. So I'm just trying to understand. So this is in progress, and we're working toward alignment with our different payers.
that's correct.
Okay.
And bringing this information together in one place so that it then can be drawn out by providers participating in value-based payment. We anticipate that there are efficiencies to the information living in being unified and living in a central place. There are, and it is then becomes a resource that providers can draw on that can accelerate the progress and can also free provider resources to focus on harnessing that data for quality improvement and harnessing that data for efficiency, rather than having to be the aggregators of the data themselves, or to be chasing the data where it lives in different places to try to understand a fuller picture of healthcare quality and spending.
Okay, and it does offer greater transparency overall, I think. So, but that's another story.
Ina, just to follow up on the chair's question, this says claims and clinical data. So the claims data is just about payment, but the clinical data is the health data. How does that integrate with the various charting systems and patient databases that providers use, because they use a whole different slew of them? And isn't that just double the work for providers?
Providers today access the HIE in a variety of ways. So providers are and do access the health information exchange, for instance, today. That the way that looks is different depending on the electronic medical record that providers are using, but it is something that happens today. I do want to be clear that we would expect that this information it's not necessarily harnessed at the point of care for a provider. Rather, it's harnessed at the provider level, such as the network. One Care Vermont is a network of providers coming together to provide higher quality care. It would be at the network level that this data may be used rather than the point of care. So the network would be looking for patterns of care, looking for places for improvement, and then bringing that out to providers and facilitating that change.
Right, but the point of putting the data in the system is at the provider level.
The claims data comes directly from healthcare payers.
But what about the clinical data? That's what I'm talking about. The clinical data
data is already flowing into the HIE.
From the providers, though, at the point of care.
Right.
Yes, it's already a part of their, it's already happening. It would not be a new step. It would not be a new undertaking.
Okay,
It's also, it's my understanding and talking with some of the docs who use it, that it provides for accessible information, patient information. And in my own area during the cyber attack on our hospital, it was the only way that primary care docs and others could access patient information. It was read only. They couldn't enter data, but during the cyber attack. And I think we talked about that when we were updating our uh, S117. But anyway, we'll keep going, Ina. But this is all helpful.
We also recommend that, and the agency is partnering with OneCare Vermont and delivery system users to evaluate the efficacy of the Care Navigator platform. The Care Navigator platform, we found in putting together the implementation improvement plan, we certainly found that there were users of the Care Navigator platform that were not benefiting from it as a tool for care coordination. We think it's very important to assess whether this is the right tool for care coordination. If it's not the right tool for care coordination, we need to work together to understand what would be a better way to facilitate care coordination. We will also.
Can I ask a quick question while you're going along?
Mhm.
When you say we, and so there's a lot of analysis going on here. Who's the we? Is that AHS and Green Mountain Care Board?
These recommendations are largely specific to AHS.
Okay.
So when I say we, I mean the Agency of Human Services Office of Healthcare Reform is actually partnering with OneCare on this evaluation currently.
Okay.
The Office of Healthcare Reform, which includes the Blueprint for Health team now as well, are in the process of doing stakeholder interviews, is assessing other care coordination tools, and understanding where there are gaps in terms of care coordination that Care Navigator is or is not filling.
Okay.
That's the we on this slide. In future slides, AHS won't be the primary subject of the recommendation. So I'll make that clear when I move to the next set of recommendations.
Thank you.
We're considering how we can take a phased approach to condition provider participation in the Blueprint with participation with OneCare Vermont, or with an ACO. Again, OneCare Vermont is the only ACO that's participating in this model, but OneCare Vermont. The Blueprint for Health, as you are also familiar, is a healthcare reform initiative that is focused on the primary care medical home. The Blueprint for Health includes primary care providers in the state of Vermont who are participating as patient-centered medical homes and are certified by NCQA standards as such. And the program also supports these primary care providers with dollars for community health teams. And those community health teams include a complement of services that are beyond the traditional primary care services and improve care coordination for patients, provide for mental health and substance use disorder services, and other services that are important at the community level. Because, as we said, our focus is to move more payment away from fee-for-service and to value-based payment models. We think that our healthcare reform initiatives should be aligned in this direction. which is why we want to explore whether providers who participate in the Blueprint for Health should also be a part of a model that is receiving, or that is a part of the fixed prospective payment or a value-based payment design. We have taken one small step in this direction since this implementation improvement plan was published in November, and we have provided for a small Blueprint community health team increase for those healthcare providers that are taking risk in the Medicare program. So that small increase is for the Medicare portion of the community health team only. So it's a small incentive for providers to be participating in the value-based payment program with Medicare in particular. Recommendation 15 is for AHS OneCare and community providers to improve collaboration to strengthen integrated primary, specialty, and community-based care models for people with complex medical needs and medical and social needs. And in order to do this, the Agency of Human Services has also organized our Vermont Chronic Care Initiative and the Blueprint for Health in the Office of Healthcare Reform in the Secretary's office. And that has occurred since this recommendation was made. AHS OneCare Vermont and community provider partners should identify a timeline and milestones for incorporating social determinants of health screening into the standard of care in health and human services settings. Additionally, through the Blueprint for Health, we will jointly explore with OneCare and stakeholders the best available tools for capturing real-time patient feedback and to pilot such a methodology with willing primary care practices. This recommendation is in the interest of our goal to improve access to primary care and to have a better understanding of how the payment model and how the value-based care design is immediately impacting persons who are receiving primary care. The final recommendation in this category, which again is largely directed at AHS, but this time is a dual recommendation. The Agency of Human Services and Green Mountain Care Board will prioritize regular stakeholder engagement opportunities to discuss progress within this agreement, as well as to address a future potential all-payer model agreement. And we have used existing stakeholder forums to invite feedback about the current model, how it is being operated, and to use that feedback, to take that feedback to inform a potential future agreement. Yes.
So how do you define stakeholders? Like who is in the stakeholder groups that you're meeting with?
To date, we've met with the Green Mountain Care Board's Primary Care Advisory Group, the PCAG. We've met with the Green Mountain Care Board's advisory group. The Green Mountain Care Board holds an advisory group, and I've presented to the Medicaid and Exchange Advisory Committee as well. That is not the waterfront of stakeholder engagement. We have additional stakeholder engagement to do. AHS in particular needs to lead on the consideration of whether additional Medicaid services are included in a future agreement, and we will be engaging directly with those Medicaid service recipients of long-term care services, home and community-based services, and particular mental health and substance use disorder services.
Okay.
That's not the full-fledged stakeholder engagement plan, but I'm certainly happy to come back and talk more about a broader stakeholder engagement plan.
Okay, thank you.
This set of recommendations focuses on the regulatory and regulation of a value-based payment model. The GMCB and the Agency of Human, the Green Mountain Care Board and the Agency of Human Services will request that Blue Cross Blue Shield, MVP, and OneCare Vermont identify clear milestones for including fixed prospective payments in contract model design. This recommendation is speaking very directly to the need to convert more payment to fixed prospective payment, because we've seen the benefit of paying this way in our Medicaid program. Additionally, because our Medicaid program is garnering more participation, we believe it's important to move more payments into the fixed model with commercial payers as well. And finally, to facilitate that flexibility for providers and to strengthen the incentive so that more payment is in the new revenue model versus the old revenue model, we need more commercial participation. One of those milestones, speaking of primary care in particular, one example milestone could be how fixed prospective payments in particular are modeled and directed for primary care providers, in addition to those who participate today in fixed prospective payments.
So this, I mean, embedded in that, embedded in each one, there's a lot, but in this one in particular, looking to identify some equity in reimbursement, because we continue to hear that with the fee-for-service world, there's inequitable reimbursement, particularly for independent primary care folks. And so as this is developed, contract model designs are developed, what is in this development process to ensure fairness?
Again, the contracts, ultimately, the contracts are between the payers and OneCare Vermont. They are, and then OneCare Vermont holds contracts with providers. We make this recommendation because, as I said, we know that we would like to see more contracts that include these fixed prospective payments. Our interest is at the contract level, in there being more fixed prospective payment to the provider network that is OneCare Vermont, for it to then work with its network of providers in terms of their contracts and how those are designed. So we're really looking at the contract level between the payer and OneCare Vermont.
Got it. Thank you.
With this recommendation.
Senator Lyons, could I ask?
Yeah, no, you're going to have to just speak up. There you are. Go ahead.
Thank you. Ina, why does OneCare not include Medicaid people who are also on Medicare?
OneCare does. There are beneficiaries that are duly eligible for Medicare and Medicaid programs that are attributed to OneCare Vermont. When they are attributed, however, they're attributed for one payer. The payer that they're attributed on behalf of is Medicare in that case. But they are not excluded by any means. They are persons who are duly eligible for Medicare and Medicaid are attributed to OneCare Vermont.
Okay. And I have a bunch of other questions, but I think I'll wait until you're finished. Thanks.
Next recommendation, under the authorities of both ACO and hospital budgets, the Green Mountain Care Board should explore how ACO participants can move incrementally towards value-based incentives with the providers that they employ. And this recommendation is intended to encourage there to be some understanding of whether or not the providers that are so imagine that a hospital is accepting and is participating with OneCare Vermont. The overall objectives of this model, as you know, are to improve health outcomes and to improve the quality of services that are delivered. We're recommending here that there be a discussion about whether there are incentives for providers for delivering on those improved outcomes, meaning is there a potential structure where a bonus, if you will, is provided for the quality of care rather than the volume of care, as an example. That's what we're interested in here. Annually, in its budget presentation to the Green Mountain Care Board, OneCare Vermont should identify cost growth drivers across its network and detail its approaches to curb spending and improve quality. This recommendation is really tied to the next set of recommendations that are directed at OneCare Vermont and that are focused on asking OneCare Vermont to identify its core business and to identify strategies for perfecting the core business of an ACO, which is certainly to be focusing on efficiency as well as quality. So where are there opportunities for savings in healthcare? Where are there opportunities? And there are plenty for quality improvement. The final group of recommendations, as I said, are for OneCare Vermont and are based around strengthening the ACO's leadership strategy. OneCare Vermont should elevate data as a value-added product for its network participants and support providers in leveraging this information for change. So both for making more efficient pathways of care, as well as improving the quality of care. OneCare Vermont should focus on entrepreneurship and how the ACO can ease providers' transitions to a value-based payment and delivery system redesign program. Sorry for the typo there. OneCare Vermont should identify and perfect its core business, as I said, provide useful, actionable information and tools to participating providers, including improving how it packages data for providers. Getting back to, and that links to our recommendation about making more data available that is linked claims and clinical data, making more data available to OneCare so that it can then focus on how it packages data for providers. Fostering a culture of continuous improvement, innovation, and learning through a focus on data, systems for improvement and tracking results. And finally, improving transparency and responsiveness to partner requests for information are all places where we recommended OneCare focus in terms of strengthening its leadership strategy. Some of these recommendations are informed in the report that we produced and published in November. These recommendations, certainly some of them are informed by literature about high-performing ACOs and the activities that are core in the business of high-performing ACOs, such as providing actionable information and tools to participating providers and fostering a culture of continuous improvement. that concludes the recommendations. I will also make sure that you have the full report if you should choose to investigate further, or would you like to go deeper into this topic?
All right, terrific. Right, it would be helpful to have the full report. So I guess the general question is that there are a lot of recommendations here that have been developed by AHS and Green Mountain Care Board, and many of them relate to One Care Vermont. So what is the guarantee that any one or more of these are going to be implemented? I mean, and this actually a question that we'll have to ask ourselves and consider is what, if any of these, which of any of these might be helped along through legislation. I mean, knowing that legislation can have an effect on change. So your thoughts as you were going through and building the recommendations and identifying places where obviously there are places that are easy or easier. Nothing is really easy. It's all complex. But so your thoughts in that general area.
As I reviewed the recommendations with you, I certainly, some of them have been fully implemented at this time, and others we are very focused on implementing at this time. We are very focused on the claims and clinical integration. We are very focused on increasing the number of fixed prospective payments through our Medicare relationship, as well as through the commercial avenue. And we continue to be
Okay. Yeah, no, I think that's the best that anyone can say. It's a big, complex process, and appreciate all the time and effort that you put into this. There's a lot here. I have one more question. I know that Senator Hardy has a question, and probably everybody else. One of the goals for the implementation of all of this is to reduce cost. And some of the concerns are putting money back into patients' pockets, so it's healthcare is less costly or more affordable. One of the goals is to reduce suicides, and so improve quality. I should have said that, but so just on I want to pick apart the interest in reducing some of the suicides that are associated with substance use disorder or other causes. Where is that in the process?
So first of all, we have these high level goals that are for the state of Vermont, and the high level goals are measured at the state level. And then there are certain activities that are happening in the healthcare system and services that are being provided that drive towards those goals. And there is a very artful framework, if you will, for quality improvement that is in this agreement that matches those high level goals to the system level activities that would, or that the hypothesis is would feed or impact on those goals. However, the healthcare providers and the ACO alone are not going to be able to impact some of these high level goals without partnership with the broader system of care. I want to emphasize that the federal government was very interested in having population level goals that were being addressed by the healthcare system in tandem with or in partnership with a state and its programs. So to make clear that through the agreement, we don't expect that the healthcare providers participating in OneCare Vermont alone do implement all of the or do all of the work to move the dial on those highest level outcomes. But we want them to do the work collectively. It's a collective goal. And so when it comes to performance on the metrics that drive those high level outcome goals specifically, I would encourage you to talk through that quality framework and the performance on those precise metrics with the Green Mountain Care Board if they are willing to do so. I'm reasonably sure they would be willing to talk with you about the quality framework for the model and how that works specifically. The ACO with its structure and its more flexible ability to partner across the healthcare system does have a network of providers that are diverse in nature and that and whose work specifically is in the avenue of the provision of mental health services, the provision of substance use disorder services. And so there is the provider network is integrated in that sense and working towards those goals in a more unified way through the ACO. Investments that the ACO can make in its care coordination model for identifying Vermonters who are at risk. It's important that the ACO be able to continue making those sorts of investments that can help to address social determinants of health. Also important for the ACO to be able to continue in that vein.
So I want to allow others to ask questions, and I see that we have our next topic coming into Zoom, but it seems to me, and what I'm hearing you say is that there are a lot of population health outcomes that we're looking for. It also seems to me that we're trying to evaluate this in the short term when we're probably looking at longer term goals. And I'll just leave it at that. We'll try to catch up on that at some point, and then how that saves money and puts money into the pockets of individual patients is the other difficult one to respond to. But Senator Hardy, you had a question.
I do, but I know that Senator Hooker has a question too, and she has, I'm going to defer to Senator Hooker because I've asked a lot of questions, but I do have one more if we have time.
Thank you. And mine is really pretty basic. I mean, you're looking at an implementation improvement plan that has obviously been brought to this point because there were inefficiencies or insufficient goal progress towards the goals with the ACO. So can you just give me an idea of what kind of gap there is between what was the original goal and what we've achieved so far? And then I had some questions. You talked about the risk for hospitals and getting more hospitals to join. How many hospitals are there now in the program? And where did the risk go that if it was taken off the hospitals, where's the risk now residing in this?
In the Medicare program, there's more risk is staying with Medicare in terms of the risk corridors have been reduced so that more risk stays with the payer program. I can share my screen again and go back to what I think are the most demonstrative and link to many of our recommendations, which is the scale targets. And I should say too that we did hear from our partners at CMS that we were not meeting the scale targets, and they asked us to respond to that. We responded with a letter, which I believe the committee or it has also been provided, that reflects many of these, or includes rather, many of these recommendations. And CMS has responded to that letter to accept our recommendations in how we would approach that, if to use your term, deficiency in scale. So I think that's important to note as well, that many of the recommendations presented today were presented to CMS in a letter where we responded to the less than acceptable level of scale that we had reached in this model, and where CMS has responded to us that it accepts these recommendations as reasonable ways to try to improve performance in the agreement. But I'll go back to
I
the,
was just going to say, going back to Senator Lyons' comments about, this is a big job. It's a big task. And I'm wondering, you had a lot of short-term goals, and then you had midterm goals, longer-term goals. What happens along the way if these goals aren't met?
if the goals aren't met along the way, we're not going to be successful we're not going to be able to move the dial, if you will, on improving the amount of movement we're seeing as a state away from fee for service. We'll have less traction to influence and moderate the cost of healthcare and the quality of healthcare.
So are there other alternatives as we move along and find that, this maybe isn't going to work? I guess that's my question.
We're very committed to moving away from fee for service. The fee for service reimbursement model is and has proven that it does not emphasize health, rather it emphasizes treating people in an acute condition. We're going to continue to push to move away from fee for service as a state. It is to our benefit.
I wholeheartedly agree with that. My question is there another way to do it besides the model that we're using? So as we go along, if we see, that this isn't working, this is you're in the 4th year of the ACO.
Yeah.
How much time, what kind of time frame is there on this implementation plan? And where's the first benchmark where we say, yep, you've been given this opportunity, you've met it or you haven't met it?
Yeah, I think thank you for helping me better understand your question. I think we need to, as the goals lay out, the short-term goals are really for 2020 when we started the plan in 2021. If we aren't able to make progress on some very significant progress in some of these ways for the final performance year for 2022, to see some changes in 2022, I think, and that is our final performance year, I think that's going to be a significant factor in how we think about approaching a next agreement.
Thank you, Ina.
Thank you.
Senator Hardy, one last question.
Yeah, and mine is similar to Senator Hooker's question, and I see our next witnesses on the screen, and I've sort of asked them the same question. It seems to me like there are 3 big players at the state level. There's DVHA and your office, there's the Green Mountain Care Board, who are next up, and then there's the ACO. And sorry, my printer's going off right at the worst time, but
We can't hear it. It's okay. It's not
okay, good. And so it seems like it's possible that not all 3 of those players are necessary, and that I heard you say multiple times to answering my questions that that's a private contract with 2 private entities, and we can't control that private contract, or we have very limited amount of control over this private contract. So I'm curious, do we need the ACO? Can't Green Mountain Care Board and DVHA and your office be the 2 players that are doing this payment reform model, moving away from fee for service? As Senator Hooker said, I completely agree that that's the direction we need to go. I'm just not sure that we need these three big players. It seems cumbersome. It seems like we have less control. It seems like, there's less transparency and it's confusing for people. So and you don't have to answer that, Ina. I know I'm putting you on the spot, but just like, that's my takeaway from this in part is the system we have right now, we can't control enough to meet our goals. It's confusing, it's cumbersome, and it seems to be expensive. So
I'll answer that briefly. As we described, care is fragmented today, and care is not coordinated. So we do need a way that providers can work together to better coordinate care. ACO or not, I do believe that there needs to be some framework so that providers are able to work with one another in an integrated fashion to better coordinate care. There has to be something to answer that need, because that is a part of why people experience care in a way that is a lower quality outcome than otherwise.
That's certainly fair. The question is, does it have to be the ACO, or is there a public model that can do that better?
I think
it's all legitimate questions. And then, an understanding that as we're looking at when I hear the phrase care coordination, I think of folks who are in primary care and then accessing through a case management system, mental health counselors or substance use disorder counselors. I think of our older population accessing SASH or other long-term care facilities and services. So having that coordination has been is important for patients. And then the quality metric analysis, where we're putting together data, quality and clinical data, and then identifying what makes for the best outcome. That's also a coordination that probably can't happen with something, an entity. And right now it is going through the ACO, and Green Mountain Care Board has a bit to do with that as well. So it is complicated. And what do we do to keep ourselves moving forward and not getting stuck, but at the same time, making sure that patients have access and savings? So these are all really good questions and observations. Appreciate it. So Ina, thank you so much for coming in. The work that you're doing is sometimes thankless, but I will, for one, say thank you very much. You've done a lot, and the work that you presented to us is Herculean. Again, it's a lot of work, and appreciate the time that you've taken to explain it to us very carefully. I think it has helped, and everyone has questions that need answering, and that's usually a good thing. Thank you. All right, and you're welcome to stick around while we have a dialogue with the Green Mountain Care Board folks who are here. We started talking about the reimbursement report that has come to the committee, and I think it's very much a part of what we've been talking about. So I see that Sarah Kinsler and Robin Lunge and Alina Berube are all here, so welcome. And
thank you.
You've been, we are a little bit late, but I'm hoping that you can sort of stir up the conversation that we ended with last time. And it is the reimbursement number 3, but I think we were more interested in reimbursements 1, probably, and 2 a little bit. So maybe
Yes.
a quick review would help us, and then we'll get into conversation. So, and I would ask the committee to please contribute and ask questions as we go along, unless Robin isn't willing for to have that happen.
Of course.
Okay, good.
Of course, I'm speaking for Sarah and Elena, who may be more put off by that than me. Having spent, over a decade, either working at the legislature or interacting with you guys, I am happy to have more of a conversation. So whatever works. So Sarah, do you want to pull up the slides? And while Sarah's doing that, I thought I'd just put a plug in for the fact that when Ina was talking about stakeholder engagement, the board around the all-payer model, the board does have an open public comment period that related to that to hear any and all ideas. So I just want to put in a plug that is currently open. So we'll jump right in. So Sarah, could you advance slides? I think we included the statutory charge, but I think you know that by now, so we'll skip over that.
Wait, Robin, can I just interrupt for a quick, is this on our website yet? Or is this a
Yes,
continuation
yes,
of a previous thing?
it's on our webpage right now. It's under Sarah Kinsler's name, I think.
Yes, I believe it is on your website.
Okay, thank you.
Yeah, and you'll recognize many of the slides. We try to reuse and repurpose and recycle our slides. So again, so the Act 159 Section 5 report is focused on regulation of provider reimbursement. We're suggesting you focus in on the key problems that you would want to solve with this, and considering the options with an eye that cost containment and value-based care are central to our reform efforts, and that we went in some depth into the tensions between different policy goals. We were not going to review that, but if in your conversation you want us to go back to that, happy to. So next slide, Sarah. All right, so I think Elena is going to jump right in with the first of our 3 high-level options. You'll notice this slide looks a little bit different in that we have broken out into the sub-options. So what we were going to do is a high-level overview of the sub-options for options 1 and 2. So I'll turn it over to Elena.
Okay, so the first option is health systems budgets. And I don't know if you remember, there was this giant table that we had that talked about kind of the different approaches that you could kind of layer on top of each of these options. So coming from a provider perspective, here we have an ACO perspective, and we also have an insurer perspective. And we also talked about a service-based perspective, which is I think less relevant here, but a health systems budget, as a reminder, is a cap on spending for some portion of the healthcare system. So it could be a provider organization, facility, or a network of providers, which is essentially the ACO. Generally, these budgets are set prospectively with a defined amount, a prescribed enforcement mechanism, or it could also include a payment methodology. So we talked about fee-for-service or more fixed prospective payments. So that could be a design element within a health systems budget. These budgets could be set, at an aggregate level on an all-payer, across all payers, or for a particular payer. But the idea is that you're impacting total spending rather than kind of setting a unit cost and letting volumes fluctuate. So as I mentioned, this option, we've kind of looked at provider perspective, an ACO perspective, and an insurer perspective. What this allows you to address is kind of unit cost and utilization, as well as value-based payments. So, while I said it focuses on the aggregate level spending, when you set those payment methodologies, you can set that unit cost. And for example, in Maryland, as we talked about last time, that utilization may fluctuate, and then you can adjust the unit cost to get to that total budget. So that there's a kind of continuous loop happening, and to make sure that you actually hit that budget, which is different than what we have. Although we set kind of this aggregate level spend for our hospitals, they can blow through those budgets, and we don't have a great mechanism for actually enforcing and constraining that spending. And then there's also, this helps address the conflict between sustainability and cost containment and affordability in the regulated sector. So Pennsylvania's health system budget approach, which is focusing on the insurer side, is really about ensuring the sustainability of rural hospitals and providers. so that when they do see decreases in utilization, because they are so small, that they are still able to keep the lights on. And then the impact of minimal reimbursement increases in public payers. So this would allow you to kind of balance perhaps different inputs from various payers and potential kind of relative contribution towards the total budget. And you can, you can look at kind of their relative contributions anyway. So what issues are hard to address with this approach? So the lack of market power for smaller or currently unregulated providers. So this would, increase the administrative burden for these providers that are currently unregulated. If you were to kind of expand beyond our hospital budget process, that would be a significant lift. And then we talked about the cost estimates. It's really quite a large range, but would take some significant work to kind of get this implemented, and then perhaps ongoing operations, you would see some economies of scale over time, but we'd really have to understand more about how we would be designing it and some of the design elements in order to hone in those cost estimates. I think another thing just to point out here is that there are some similarities in the ACO health system budget to our current model right now. I mean, I think one key difference is the voluntary nature of our model, and the board's role in regulating that model is really about providing that transparency, but it's really up to the ACO and the providers to set those payments and to opt into those payment methodologies. So, those connections in the all-payer model improvement plan, the board doesn't really regulate at that level to require those kinds of payments, but we do kind of track participation in those payments over time. Okay. Go to the next slide. So, I think I've talked about these, but here's a little bit more detail on each of them. So the option one, focusing on the provider lens, would allow, we'd evolve the hospital budget process, or we could evolve the hospital budget process to set provider specific budgets. And you could do these based on with population-based payments. So fixed prospective payments based on a defined population. And then you could prescribe a particular methodology. The second option is to evolve the ACO regulatory process. So as I mentioned, right now it's really voluntary, and we're really providing more of that transparent and goal setting lens. But we could evolve it to make it a more mandatory hybrid in which the board could set those payment methodologies and amounts. Then in the insurance regulation option, you could require insurers to use population-based payments. So this would adapt our rate review process. So it would only affect that population. But you could essentially track those payments on the other end as well through the hospital budget process.
So just landing here for a minute, there are going to be some federal impediments to doing some of these things, and in particular, I'm looking at the last one. But so as you're going through this list, there are some things that a state can do, and then there are some things that a state categorically cannot do without having a waiver or some federal law change. Maybe you could talk a little bit about that.
Yeah, and I'll ask Robin too, because she's our master waiver.
I was looking right at Robin when I said that.
Sure. So why don't we start from the bottom up? So in terms of option 1C, we considered this to really mean the insured population, which, as we talked with you about earlier, is relatively small in that it includes about 95,000 people total between the individual, small group, and large group markets. So this option, we did not consider that it would impact the self-insured population because, to your point, Senator Lyons, under federal law, the state can't direct how that works for self-insured employers. We have heard, for example, in Rhode Island that some of their insured market some of their insurance market options that I'll talk about more in option 2 did have a spillover effect, meaning that the carriers then would offer that voluntarily to their self-insured marketplace. So I think with this, the con of option 1C is that it is a relatively small population. The pro of that is that it is a population that has started to work on fixed payments, but at this point has not fully adopted those. So it could kind of address some of those issues raised in the ACO improvement plan. There aren't any federal issues. Well, so for option 1B, the federal issues related to would be related to the payment methodology. However, under for Medicare. So let me start with Medicare. So we could, under the ACO process, we could establish payment methodologies and amounts if you were to go in this direction, not under current regulatory authority. For the commercial population and for Medicare, our existing agreement does allow us to propose new payment methodologies and revisions to the current one. So I think that would require a process. It might not be immediate, but we could work to align that there. And then with the hospital budget process, the way, if we wanted to include the authority around Medicare and Medicaid, that would necessarily require some additional waivers. However, of course, we could kind of work on that through different ways. So for example, if we know the DIVA payment methodology of fixed prospective payments is satisfactory, we wouldn't necessarily, the board would not have to change that. That could be just an input into the budget, right? And I think one of the issues that Elena alluded to in the previous slide is that in our current hospital budget process, the Medicaid payment changes are just usually an input into the hospital budget process because the board doesn't set Medicaid reimbursements or trends. And so I think if you wanted to look at that, there'd have to be some deep conversation around how does that work with the existing state budget process? Because quite frankly, the existing state budget process really kind of directs how those Medicaid funds work now. So I think you'd have to think through whether or not there's a value add for the board to be involved in that, or whether we take what you say as a given, although it would be good to maybe have some feedback so that you could see the impact of different Medicaid changes on, for example, the commercial sector. For Medicare, again, this would be, I think, part of a next agreement or next negotiation with the federal government to really include them seamlessly in this. So as Elena said, probably option 1A is the most complex out of, in terms of design elements for all of the options that we're presenting. On the flip side, it does have potentially the biggest impact in terms of population and dollars. So you have some trade-offs there. Elena or Sarah, did I miss anything?
I don't think so. No.
Okay, thank you. Questions, committee?
Just one quick question.
Yep.
These options, and the same question for the next set of options, they're not exclusive, like we could do a mix of these, doing option 1A and 1C or something like that.
Yes.
Is that right?
Yes.
Yes,
Yep,
or
absolutely.
and 1A could include 1C, right? Like, so they're if it is an all payer approach, it could include aspects of that. Yeah.
Okay, great, thanks. I love that mix and match. Thank you.
No, that always helps make it complex, Senator. We love it too. Go ahead.
All right, can we move to the next slide, Sarah? Oh, perfect. Okay. So option 2, you may recall, is establishing a regulatory entity with authority to limit provider reimbursement to a particular growth rate, which could be looked at both in terms of growth caps and growth floors. So, for example, setting a minimum growth target for certain types of services or providers and a cap on other providers or services. We talked about this in terms of, as an example, for if we could set basically a floor for primary care growth, but then we'd have to figure out where else in the system we wanted to constrain, if we want to constrain overall costs and really consider affordability for consumers, which we kind of assumed throughout the report that that's still a central goal, that raising provider reimbursement should be done in a manner that minimizes affordability issues for consumers. Again, there are 3 approaches, which I'll go through in a moment. This approach could, as I just said, prioritize growth for certain sectors or providers and limit growth for others, which could address different issues in the existing system. It does really highlight the winners and losers in the provider sector, however, so that that is now somewhat masked in the fee-for-service system. And it could, over time, counterbalance some of the lack of market power for smaller practices or smaller providers. It doesn't do it in one fell swoop like a fee-for-service rate setting system where you're going in and just really changing directly the underlying concerns about the existing payment structure, but it could shape that over time. It, again, is not really focused on total spending, although when combined with other regulatory processes like the hospital budget process, that would you would get to that. And that's because it's not particularly targeted at utilization. It's really looking at cost or unit price. And then lastly, it does not look at the sustainability of unregulated providers. So in the hospital budget process, because we're looking at the revenues and expenses of each entity, we can have that lens. But this option doesn't suggest that we're going to start looking at it, each and every provider in a particular type, to be able to assess their individual sustainability or financial health. The cost estimates here are more modest because really what we're doing is establishing policy level direction or requirements, I should say, which are then implemented in the private marketplace between the providers and the payers. So the cost estimates are 70 to 145,000, and that range depends on which option we're talking about, and then ongoing operations are 10 to 270,000 a year. So next slide, Sarah.
Other questions about that? The range? No, okay.
So to drill down a little bit more, there are 3 different ways that we came up with to implement this type of concept, 2 through provider regulation, 1 through insurance regulation. So option 2A would again evolve the hospital budget process to really look beyond the rate setting that we currently do in that process. If you may remember from last week, I talked about how we set a cap on charges, which is the amount that then gets negotiated down in the commercial sector. This would have us go beyond and really take a better, more nuanced look at that, perhaps being able to understand the reimbursement, the actual reimbursement as opposed to the charge level, and also taking a look at things like professional fee schedules that are not based on charges and so are currently unregulated by us and subject simply to the negotiation process. And certainly this type of entity level look could be extended beyond hospitals. However, I think It does, as we said before, this can get quite burdensome for the regulated entity. And if you're looking at something like primary care practices, that's a lot of new providers to start regulating at the commercial and expense level. So pros gives you a better sustainability look. Cons, a little bit hard to extend beyond hospitals, but it could be a natural way to evolve our current process to be more nuanced in its regulatory approach. Option 2B would be to set minimum and maximum reimbursement growth trends for a let me address the federal issues while I'm going through this so I don't have to go back. So on the first one, because in the current hospital budget process, we accept Medicaid and Medicare as givens, and really then the budget essentially gets balanced on the commercial ask. This doesn't require any federal change. So back to 2B. Service-based growths and caps. So we would be setting a minimum or maximum reimbursement growth trend for a category of services or a category of codes. So for example, professional services could be a category, and these could be rolled up or down to various levels. And that's part of what we'd have to explore, is what kind of categorization or chunks does it make sense to set these caps or floors. So this is similar to what Rhode Island did in their insurance market, where they said you have to have a certain amount in primary care, you have to have a cap on hospital growth. But what we would do in this particular option is establish that as provider regulation, which would take the form of under existing provider regulatory authority doing a rule after a bunch of study, actually, to figure out what makes sense to what level to set. And then the real trick on this one is figuring out then how do you know it's actually flowing through the private market, and B, what's your enforcement if you've set a trend and someone doesn't follow it. So those are really the areas that make this one a little bit tricky. We would be setting it pretty much for commercial. Well, we'd be setting it at the provider level, so it would impact all commercial, including self-insured employers, because we're not actually regulating the employer, we're regulating the provider. So it does get a bigger chunk. We'd have to also work through Medicare and Medicaid, because those are already in Medicaid, the legislature could certainly then follow. Like if we did a rule, the legislature could choose to follow those trend rates that we set or not in the budget process. And then with Medicare, I think it's unlikely they would be interested in participating in this type of model, simply because, at least not alone. If we could figure out how to combine it with a value-based care proposal, then I think they would be interested. But really their authority is around looking more around specifically to value-based care. So there's definitely more thinking and work that could go into this about how Medicare could be included, but I think we would start with what we can impact as a state. And then lastly, on the insurance side, this really is basically the Rhode Island model, where in our insured marketplace, which again, this is the 95,000, so small population, you would give us additional authority. This is not something we have authority to do now, where we would be more directive in the premium rate review process about trends. Right now, what we do is we review projected trends. In general, we do look at utilization, we do look at price, and we do a true up with what we're expecting to happen in the hospital budget process. So there's a little bit of true up in what we approved there, but it's really a review of a projection. We don't have the authority to set conditions or do the kinds of policy level regulation that Rhode Island does in their process. And that, because that's in insurance, we don't need any waivers, but it does only impact that insured population. So I will pause there.
Whoops. Oh, there. I was muted. So Robin, Sarah, and Elena, this is again, this is great. It really is helping everyone understand where we are, and what the possibilities are, I think, going forward. And the committee is very interested in that. So I guess my question is, given that we did start you a little bit late, and I just hope you can understand.
Oh,
why.
of course.
I
Yeah,
think.
no,
But,
absolutely.
and I'm wondering if there is any possibility of, we've asked the Green Mountain Care Board to come in tomorrow talking about primary care and the all-payer model, a little bit, your involvement in that. And I'm wondering if this actually tomorrow might be an opportunity to continue this discussion with you. I don't know how long it would go on, but I don't know what your availability is, so.
I'm available. I have a meeting at 10. I just need to check on to see if I could miss that 10 to 11. I don't know what time you have this scheduled for.
Yes, I can tell you right now, we have it, whoop, I went to the wrong day. It probably wouldn't begin until 10:30.
Okay, so let me check in about my other meeting to see if I can shift that.
I think that would be extremely helpful. We're going to go through 2 bills tomorrow on sort of healthcare reform implementation. And some of the comments and the options that are here might relate to one or more of the bills in terms of what we should be doing going forward. So let's say if you're available at 10:30 and our committee ends before 11:30, it would be very helpful to have you here.
Yeah. And I don't know what Elena and Sarah's availability is, but I'm sure.
I can make that time.
Great.
Yep, same here. Thank you.
Okay, that's terrific. So we'll do that. And then Nellie has also sent out a request for information to the Green Mountain Care Board, and it may deviate somewhat from what this is, but I think it all fits together ultimately, and whatever we can learn, I think will be important. So
Great.
good.
Thank you.
Thank you.
Part 3 to be continued.
Yeah, part 3 circling around to parts 1 and 2 and the never ending cycle. So we greatly appreciate your time.
Madam Chair, can I just ask
sure.
a couple quick questions? One is, have you all done this presentation for our counterparts in the other body?
Not yet, no.
Okay, is that on the horizon?
Not that I've heard, but I can check with Representative Lippert.
Okay. And then the second question is, if we were to do some kind of mix and match outfit with this, what is the, what do you think is the timeline that we would need to put something together? I mean, I suppose that depends on what options were chosen, obviously, but just,
Yeah.
is it a couple years or what are you thinking?
It does depend on the option, and maybe when we get to more like which options you're interested in, we can be more specific with that. I would say changes, something like, for example, option 1A around sort of moving the hospital budget into being more of a health systems budget, that has, because there are substantial design work that needs to happen, that's, I would say, at least a 2-year horizon. So if that were something you were interested in, we could look at maybe starting to move forward with some of the studies that we included in the larger report, because it does need more work. And then I think the other limiting factor will be COVID and how we kind of evolve in COVID, because as you know, we really skinnied down, or tried to at least, the hospital budget process this year because of the COVID issues. And so I do think it's hard to move forward on some of these regulatory changes without stakeholder engagement and involvement. And so I think that would be the other sort of unknown at this point.
So what
Yeah,
I'm going to
that makes
suggest,
sense.
yeah,
Just
thank you.
One quick thing, you have on your list of areas for next discussion is low hanging fruit. So I would
Yeah.
love to know what
we
those.
want to
fruit
hear
are.
that. We
Okay.
want to hear that. So
All right.
I'm going to suggest that a lot of the things that we're hearing about obviously are going to require greater analysis. It may even require some outside consulting in addition to Green Mountain Care Board and others. So I think the question that Senator Hardy is asking is the question that we're going to have to debate as we look at what, if any, legislation we pass with regard to this. So that's been our goal right along. So we'll continue the conversation tomorrow. Just remember where we are. And thank you. Thank you for being available. And thank you for all your good work yet again. So Nellie, we're going to end the meeting.